of psychiatry.
Sorry about that.
That's okay. In the division of psychiatry at UCL, she leads work addressing palliative care and frailty for people experiencing homelessness. She's also a clinical research fellow at the homeless charity Pathway. And Briony is an associate research director at Marie Curie, a principal research fellow at UCL, and a research associate at Pathway. And I know that together they've developed a number of tools and resources, which I'm sure we're going to pop in the chat as we go along. I'm particularly thrilled. They're kind of celebrities for me. I've already told them this because as part of my PhD, I'm doing a sort of literature review, scoping review, and their paper from 2018 and about end-of-life care for homeless people was a qualitative piece of research, is one of the papers included. So I know that paper so well. I feel like, meeting them is, very exciting. So yes, we're going to, Sheena's very kindly posted in the chat our agenda for today. So they're going to speak for about 45 minutes, and then we'll have some breakout rooms where we'll talk about a case discussion, come back, discuss that as a group, and also be a moment for Q&A. So yeah, thank you, and over to you, Briony and Caroline.
Thank you so much. I'm sure, Rebecca, you probably know the paper better than we do now, but yeah, thanks for your very kind words. That's awesome. I think probably with no further ado, should I just, as we've both been introduced, I don't know, Briony, you want to say hello, and then we can, I'll share the slides.
Oh, no, that's fine. You crack on, Caroline. We'll come to me in a bit.
Yeah, and we're doing a sort of double act here. So, okay, I'm just going to share my slides, which worked seamlessly before. Let's hope it works seamlessly again. Share slides. Share. Right, is that visible?
Yep, that's great.
Top slide, excellent, good. Brilliant. So what we're going to sort of touch on today is almost like a kind of an overview, really, on a little bit of background on homelessness, because I think that's actually quite important to get the context, really, of what we're talking about. And then a bit about our research around palliative care and homelessness, sort of what we know. So I'm going to start with the background, then Briony's going to talk about the research, the sort of challenges and complexities, and what's needed to improve high quality trauma-informed support. So I'm going to come in with addressing how to address the challenges, and then and what works, and then Briony's going to talk through some of the resources, and then we're going to introduce a case which then can be discussed in the breakout. So
you get it?
As we go. So I think it's always,
yeah, that's it, launch meeting.
Are we able to mute? I think somebody's not on mute at the moment. Okay, so I think it's always worth thinking, and I always think it's worth thinking about what a home is to us, just very briefly, when we're thinking about homelessness, because it's clearly more than just a roof over our heads. And I love this sort of definition, really, from Crisis, where a home provides roots, identity, a sense of belonging, and a place of emotional well-being. And homelessness is about the loss of all of these things. And when we're talking about homelessness, we're not just referring to people who are completely roofless, people who are sleeping on the street, rough sleepers, but also people who have no place they can actually call their home, people who have who are insecurely housed, staying in hostels, squatting, sofa surfing, or sort of staying on friends or families' sofas, floors, doorways, and also many thousands of people in temporary accommodation as well. They never know how long they're going to be there. They can't put roots down. And we know there's a huge travesty, huge numbers of families in temporary accommodation. I'm going to be focusing mostly on sort of the single homeless population, who generally speaking don't have automatic rights even to temporary accommodation. And a lot of our work has taken place in homeless hostels. But there are many routes into homelessness. There's clearly structural reasons for people becoming homeless. We know with increasing inequality, with job loss, with lack of affordable housing, sort of welfare policies can have an impact, employment rights and so on. And there's also large numbers of people who are here as migrants who have often have no access to any form of public funds at all, so people who are NRPF. But we also know that there are and many people who experience homelessness have addiction issues, often mental health issues, acquired brain injuries linked with homelessness, neurodiversity, relationship breakdowns, and contact with criminal justice. But underlying and often related to all of this, we know that there's very large numbers of people who are homeless who've experienced adverse child experiences. So many people who've grown up homeless or grown up experiencing neglect or abuse, have a parent with addiction, parent with mental ill health, parent in prison, domestic violence, parental separation, are at much higher risk of becoming homeless themselves. So there's an array of risk factors or individual vulnerabilities, as well as structural vulnerabilities and structural causes of homelessness. And trauma is profoundly present. It's 85% of people experiencing homelessness, in addition to having either a substance use disorder and contact with the criminal justice system, have experienced profound childhood trauma. So with the population we are working with, which is sort of single homeless, hostel, street homelessness, people who are in and out of homelessness, often for many, many years, if not all their lives, it's almost accepted. We know that they have experienced huge amounts of trauma. So there's trauma is a risk factor for homelessness. And also when people are homeless, they are experiencing profound trauma, ongoing trauma, both emotional and physical as well. Now, obviously, this is, you are all experts in trauma, but I thought it's worth, despite that, just reiterating the impact particularly that we see in the population. And we all know that following trauma, the body can react as though it's threatened or in danger, even if those initial threats have gone. And this can affect so much about how people are viewing the world. And we know the world may be viewed as fundamentally unsafe and others as untrustworthy. And there's often real feelings of fear, anger, guilt, and shame. And people are often struggling to articulate painful experiences. And also, I think really very relevant for all of us working in services, it's that people often struggle to understand other people's perspectives or their own emotions. And this can really readily contribute to relationship breakdown and isolation. And we also know, and I know this is really quite a basic summary really, but that emotional arousal can escalate really quickly and lead to conflict and often eviction from services. And so we see this so frequently with our population, people coming to hospital, being evicted because of difficult behaviour, being discharged from GPs and told that they can't be seen there anymore. And it's often because people are not recognising or understanding their trauma, and they are not able to articulate their needs calmly, and can often get quite emotionally aroused very quickly. And we know that there's obviously a really high burden of poor mental health, high suicide risk. And addictions are often this result of not being able to self-soothe. So there's often self-directed harm, self-medicating with substances as a way of trying to cope with these huge monumental difficulties people are experiencing, and this lack of trust in everyone and everything. And often there's clearly very poor physical health as well. So we know that trauma itself is associated, adverse childhood experience is associated with poor physical health. But in addition to that, when we add in people who are needing to self-soothe with substances and people in and out and not able to access services, this is obviously very profound. And this slide really summarizes some of those stats, the statistics of this. So mental ill health, very, very common. So 82% of people experiencing homelessness have mental ill health. and the majority of those have at least 2 conditions. So that includes depression and anxiety, quite high levels of PTSD, dual diagnosis and psychosis. Substance use, so 70% of people, 25% report dual diagnosis, with a further 45% reporting using drugs or alcohol to cope with mental health. So in other words, it is, we're talking high levels of dual diagnosis and substance use in association to try and actually deal with mental ill health. And very, very profound physical health problems as well, which I shall explore a little bit more. So we know that many people have multimorbidity, really high rates of hepatitis C, which is clearly associated with IV drug using, and TB, which is a disease of overcrowding, of destitution, of poverty. But in addition, we know that long-term conditions, the majority of long-term conditions, are very, very much higher prevalence in this population. You can see the red bars here are people experiencing homelessness. The other blue bars, the darkest is people in the most deprived 20% of the population, and the pale blue is the least deprived 20% of the population. And here you can see that the prevalence of, for example, asthma, respiratory disease, COPD, epilepsy, heart disease, and stroke are so much higher within this population than the rest of the population, even the most deprived rest of the population. So another piece of work we did, which I'll just briefly talk about, which was done with an incredible geriatrician, Rafi Rogans-Watson, who is now down in Brighton, actually, which, so I don't know if he's had contact. I know there's people from Brighton here. So we looked at a hostel in London and used markers that he would normally use in an old population. This was a hostel it was a smallish hostel, 42 residents, but mainly people who were a bit older. They had to be over the age of 30. And he used frailty score using the Freed. The average age of people that were in the hostel was 55. 85% had a history of rough sleeping. But frailty scores were equivalent to people who were in their very late 80s in the general population. And that shows there was the levels of frailty and pre-frailty. Only 6% were not frail. But also there were huge numbers of geriatric conditions. And I must reiterate, this is just a hostel, a normal hostel that took slightly older people. So it was known to have people who'd been homeless often for many, many years, but it wasn't a care home. So more than 50% were experiencing falls, poor mobility, low grip strength, poor vision. And then, nearly half had cognitive impairment. There was high levels of malnutrition and urinary incontinence. And actually everyone had multimorbidity, and the average number of conditions per person was more than 7. And yet only 9% had any form of social services package of care. And hostel staff are not trained in health or care, and they were being left to support this population. So we know there's huge barriers as well to accessing services. Health might not be a priority if you're trying to source food, if you're trying to source shelter, but the services are really not trauma informed. So there's a real fear and distrust, and people often feel unwelcome. There can be real, actual difficulties registering with a GP, even though it's absolutely unlawful to not register someone. You don't need to provide proof of address or proof of status to have access to primary care. Primary care is free for everybody, but a lot of GPs will insist on paperwork. There's also, as we know, within our services, a lot of inflexibility, and people are often discharged for non-attendance or they're evicted from services. And also a real fear of going to hospital, for example, because they will not have addictions met. There's often a real fear of withdrawing and being left languishing. And we know that from a lot of work, that people will leave it till they absolutely have no choice before they go to hospital. And the impact is that people often seek treatment when their problems are really advanced, but you're using A&E rather than any preventative services. And we know that people admitted to hospital, there's really high rates of self-discharge, and often hospital teams are only too happy for people to self-discharge if they're causing problems and they're finding them difficult to manage. And we see people often with really significant ill health self-discharging. And one of my my roles that I did for a number of years was working within a homelessness team within a hospital, and we worked really hard to try and prevent self-discharge and try and prevent people being evicted from hospital by helping people to really feel much more welcome, and working with the hospital teams to recognise the needs. But there is still a huge rates of unsafe discharge. People are not taking discharge destinations into account. And people are often then kind of rebounding in and out of hospital. And this is kind of resulting or contributing to these appalling rates of death in this population. So this is going up year on year, numbers of people dying. So over 1,400 people experiencing homelessness died in 2023. And the Office of National Statistics have sort of evidence that the mean age of death of people experiencing homelessness who are dying is in their 40s. And these deaths, we know, are often sudden, untimely and undignified, with access to palliative care being very unusual. Now, that quote comes from a crisis report in 2012, and tragically, I don't think it's much different, apart from pockets of the country where people are really working differently, particularly where there's much more support through palliative care services. I'm just going to very briefly sort of just mention Gemma and Nick to think about what the population we are talking about might present with and how they might present. Gemma and Nick are both very different, but Gemma was somebody who I met early on when I was working in a hospital team. She was 28. I'd heard about her. She'd been in other hospitals in London, always kind of crashing in unconscious and going into intensive care with liver disease. She had advanced liver disease, decompensated liver disease. She had been homeless for many years. She was addicted to heroin, and she also was a drinker. So she had alcoholic and related liver disease, as well as hepatitis C. And that combination often results in really very significant liver disease at a very young age. She didn't really know. She didn't engage with anyone in the hospital. She often self-discharged before she'd finished treatment, and usually as soon as she could walk, she self-discharged. Now, Gemma, we worked very hard at trying to get Gemma into a hostel, and she got into a hostel, but we had to get her back into hospital because she self-discharged before finishing treatment, got her back in, she went to the hostel, and then tragically died 6 weeks later. One weekend she collapsed and died within the hostel. Nobody really felt they knew Gemma very well. She hadn't really started to engage with anybody at the hostel and hadn't really had any continuity in her hospital care either. Nick was quite different. Nick was 52 when he died. He had been, again, homeless for many, many years. He'd been street homeless, then in temporary accommodation, in and out of hospital, couldn't cope really very well in temporary accommodation. So he was placed into a hostel. So that with the idea that he'd get a bit more support, which he did get, to be fair. He had liver disease and respiratory disease, but was increasingly frail. On his admissions, it was possible to see over tracking him over years, he had poorer mobility, he had poor cognition, which was increasing. He actually wanted to go into a care home and be helped to not drink. He knew that whenever he was in hospital, he stopped drinking and really wanted to stay off alcohol, but he couldn't. Whenever he went back out and he was discharged, he would start drinking again. One day he was actually discharged. He'd come into hospital. He was in intensive care. He'd been in respiratory failure. He had a DNAR, I saw him at this stage, and I was only there sort of part-time in this role, spoke to the hostel, and they said asked how they felt about having him back when he was ready for discharge, if he was at the same level as he had been before, and it was very clear that they would be happy to have him back so long as he had a package of care, which in my mind was obvious that he needed that. And made it very clear to the ward that he shouldn't be discharged on a weekend. He needed to have his methadone prescribed. He needed to have a package of care, and then the hostel would be happy to have him back, assuming he had recovered up to his baseline again. In fact, he was discharged, in fact, on a weekend with none of that in place. And adult social care had said he actually didn't trigger, hadn't reached a threshold for a package of care. And within a week, Nick died. And the hostel had to basically try and get emergency palliative care support for him at that time. The hostel staff, one of them changed their shifts so that she was with him towards the end, and he died quite peacefully in the end in the hostel. But I think the question we all have is, how can we improve palliative care for people who are homeless? So we think about these two different people who are they're both very young and with conditions which often palliative care teams don't get involved with immediately. So that takes us on to our research, and I'm going to hand over to Briony now to take us through what we found from our research.
Thanks, Caroline. It's always really useful to go through some of those barriers to healthcare in general and look at the illnesses that are common among that population, some of the challenges around access there too, before looking at palliative care and homelessness. So as Caroline mentioned, really experiences of people like Gemma and Nick were what motivated this research. And back in, I think it was 2015 or 2015, we started on a programme of research to explore that question and see what are the challenges to palliative care access and what are the experiences of people who are either homeless themselves or are supporting people who are homeless in trying to access high quality or any palliative care for people experiencing homelessness. And we started out with a systematic review, and then we did a series of qualitative research projects before moving on to developing some training and resources for different groups of staff, and then some models of care that we evaluated and rolled out as well. So in the next couple of slides, I'll take you through some of the key findings that we had from some of that early qualitative research, and then some of the things that we've done with that moving forward. Thanks, Caroline. So I'll start us off just with a quote, and this is from one of our first studies, and it's from a specialist GP. And they say, "I think that people are just resistant to the concept of them," that's people who are homeless, "being palliative patients. You're dealing with people who are still relatively young, and it's difficult." And I think that quote sums up some of those initial challenges around the uncertainty and the discomfort in thinking about people who are younger, who've had really difficult lives and who've had not the same opportunities to engage with healthcare as other people, and about how it can be really hard to think of them as palliative care patients. So moving on from that, I think we'll think in a bit more depth about why that might be and the impact of that lack of identification of who has palliative care needs among people that are experiencing homelessness. So we've heard just from Caroline's previous presentation that many people who are experiencing multiple exclusion homeless have advanced ill health, and it's often at a much younger age than the general population. And we also know that this group, as we've seen from the frailty research, experience accelerating aging. So they're experiencing conditions that are normally associated with much older people much earlier on. So, and people are often dying at a young age. So we're just not thinking about palliative care potentially for those younger people. And linked to that is uncertainty around disease trajectories. So further uncertainty comes from the characteristics of illnesses like liver disease or organ failure, which we can see in the dotted red line on that graph here, on the graph on the right, and how that decline in that trajectory is really unpredictable and is marked by periods of crisis and then recovery and then crisis and recovery, and you're never quite sure which crisis will be the last. And that makes it extremely difficult for palliative care potentially to think about when's the right time to intervene. And when you think about that in comparison with trajectories of things like cancer in the blue, dark blue, you can see how that's a much more predictable trajectory, and it's much easier to know when palliative care potentially could get involved. So added to that, there's complexity related to trauma and substance misuse disorders, which can sometimes substance misuse could mask symptoms, making it hard to know what's an illness-related symptom and what's a substance misuse-related symptom, and that can make it even further harder to know when to begin palliative and end-of-life care. And we've heard about the barriers to accessing mainstream services in Caroline's previous slide, but when this is coupled with a real uncertainty, a complexity, and a lack of identification, it really does make it quite cloudy as to when and how and who palliative care should help and when. And another quote here from a healthcare professional: they sort of could be classed as palliative, but if they're also reversibly palliative. So if you don't stop drinking, if you don't stop doing these things, then you're probably going to die in 6 months. And it's a little bit difficult sometimes to class them as palliative when you have a reversible cause to it. And this was a really common theme that came up in some of those early interviews about people being told that they should stop drinking. And if they don't stop drinking, then they'll die. And this is really not a helpful conversation and doesn't offer people a chance to be supported in ways that are right for them. And the often young age and uncertainty results in people not being considered for referral to palliative care services. So what we found really early on is it's just not something that people were thinking about in relation to homelessness, for all of those different reasons: that young age, the uncertainty, the complexity, and then this reversibility potentially that people were seeing. And gaps in current systems. So very many people with complex needs are at risk of dying are in hostels or temporary accommodation. So Caroline spoke about the different types of homelessness in the previous study, and a lot of people experiencing homelessness are in homeless hostels. And understandably, the model of homeless hostels is recovery, so helping people to move out of homelessness and into independent living. And they're designed to provide temporary accommodation. They're not designed to be long-term places of residence where care could come in. They're not thinking about being a care home because that's not what they're designed for. And also the staff that work in these situations in hostels didn't go into working in the sector to provide support to people with chronic long-term conditions. They were really thinking about helping people to recover and to move out of homelessness. And as a result, they don't have often, it's changing, but they don't have the knowledge about healthcare and advanced ill health, because why would they? That's not what they went into the job to do. And given that it's difficult often for people experiencing homelessness to get access to health and social care support, people are left with increasingly complex needs to deal with on their own, and they're feeling quite isolated and often go way above what is within the remit of their role to try and support people as best they can in the circumstances that they can. And often they struggle to get medical support or support from social services. And this is a really, really difficult thing to do. And there's really high levels of burnout from staff. And it's just a really difficult situation. So some quotes here from hostel staff. We're trained to do recovery. Our hostel's commissioned to engage people with support and recovery, getting better, moving into jobs, whatever. And then we have the reality of what care actually looks like. At least 3 times a shift, we check she's okay. And it's hard, particularly on weekends and nights when we only have 2 staff. And it's a big hostel with 60 residents. This isn't an appropriate environment, but it's the best that we have. Gaps in current system. So the lack of options for place of care means that people in hostels with high needs are tending to have to stay there because there aren't that many other places that are suitable or that are able to accommodate their needs. So these lack of alternative places of care are due to similar factors. So the young age of people with care homes not often being able to accept people that are younger, mental health difficulties and substance misuse, which can be harder to manage in situations or can be really difficult for staff. So a quote here from hostel staff. In the past, we've tried to put people into hospice, and one person in his 40s, we did get in there, and he was asked to leave because of his behaviour when drunk. And in the end, he died in the hostel and he had cancer. I think what we've seen from our work is that if people are able to support it in hostels, it tends to be, or get support from palliative care services, it does tend to be people that have that cancer diagnosis. And another quote from a specialist nurse. Most care homes are for people with dementia who are older. It's just our patients don't fit any of those rigid things. The care homes themselves are like, what? We don't want this 29-year-old, you know? So we looked at various things in our research. Some of those were around that lack of options for place of care and some of those barriers to palliative care access. But we also looked at some of the challenges to having conversations about people's wishes and preferences for the end of life. And we found a number of barriers to having conversations about that, and subsequently a lack of advanced care planning for people experiencing homelessness. And this was for a number of kind of interrelated reasons, and I'll just talk you through some of them now. The first was around lack of confidence. And this is related again to a number of things. One being hostel staff's understandable lack of experience in talking about palliative care and about wishes for the future. They were worried that bringing up conversations around death and dying could be quite triggering. particularly for people who may have had traumatic experiences in their past, or who may be using alcohol or drugs to block past experiences. So they were worried about the impact of bringing up things around deterioration of health or death and dying. And that was linked to concern about the fragility and the removal of hope. And hostel staff told us often that they'd worked really hard to build up relationships with people, and they were worried that if they said that they thought that they were dying, or if they had a difficult conversation, that might damage the relationship, which had been very hard earned. And there was also a lot of denial from all sides. I think that people were very reluctant to think that somebody might be reaching the end of their life, given that they wanted them to be better and to feel better and to get better. So lots of denial about whether that was the right thing to do. And again, that uncertainty of prognosis and lack of options to offer. How do you have a conversation when you've got nothing to offer in terms of a better place of care or access to different services? And when do you do it? When's the right time? How do you get going with that? And when should you begin? Is it over to you now?
Yes, so over to me. Sorry, I was just unmuting. So overcoming the challenges. Let's get a bit more upbeat now. We've heard all the sort of depressing findings from our research and what the situation is, but there are things we can do. I think, obviously, for this group, doesn't need to be said, there needs to be much more trauma-informed services. So it's really important that people experience compassionate, non-judgmental responses, and they recognise that and understanding that some of their behaviour or distress is a result of past trauma. And to help people recognise that themselves and to help staff to understand that is so important. And that for healing, we need continuity and we need time to develop trust. It's also really important to recognise the risks of re-traumatisation. And, you know, I won't go into that in more detail here because this group is obviously really expert in this, but I think it's you know, suffice it to say that we see people being evicted because they appear volatile or explosive in a response to something which is actually often related to re-traumatization, not being understood and not understanding what somebody's triggers might be. And it's really important that we shift our focus, particularly people with substance use, to help them recognize themselves that this is something that they are using to cope with and deal with what's happened to them. So rather than it's being something wrong with them, it's that they're suffering and reacting to what has happened to them. But it's also really important, I think, for staff to recognise the impact of trauma on themselves and the vicarious trauma. So they, you know, a lot of homelessness services do have a reflective practice now, which can be really, really helpful. What else is needed? Well, we need to improve identification of those that might benefit from palliative care. So one thing I would call out to all professionals working is to listen and involve the frontline staff. So hostel staff, if you say to hostel staff, oh, do you have anyone who might need palliative care? They might say, no, I've got nobody with cancer at the moment. But if you say to hostel staff, is there anyone that you're concerned about? Who is it you're worried about? Who is it in and out of hospital with physical health problems related potentially to their mental ill health and their substance use, but and who are you worried about could die from that? And I think we all also within palliative care, we need to be shifting our approach. So it's like, is this person approaching the end of life? Away from that to, does this person have advanced ill health or deteriorating health? And also kind of this idea of parallel planning, hoping for the best while planning for the worst, so that we're not removing hope. We're not removing the possibility that somebody is going to recover. But it's really important. It's also for everyone to understand that we're not giving up on someone if they've got palliative care involvement, that active treatment can continue. So as well as trauma-informed services and improving identification, we need to, I think, and there's a lot of evidence to suggest we should be thinking differently about advanced care planning when considering the uncertainty and the trauma. So instead of maybe focusing on conversations around wishes around death and dying, being much more person-centered, trauma-informed explorations of insights into what people understand by their illness, their wishes, their choices around what living well would mean for them. So thinking about Gemma, for example, it could be, you know, obviously things are difficult, you're in and out of hospital. So, you know, what is it? How do you see your illness? How do you see what's happening to you? What is it that would make you feel better? What is it you would want? Rather than conversations, which I suspect she had, which were, if you don't stop drinking, you're going to die. So it's more around empowering people to think differently themselves about their illness and about what's important to them and what living well is. And those conversations should be early repeated, really not centered, I said, about giving warnings, but also where possible exploring people's choices and respecting their choices, even if they feel unwise. Just going to very briefly share Vancouver. There's a brilliant chap, Wallace Robinson, who's done some work on this as well, looking at working with again, very vulnerable populations, people experiencing homelessness, and looking at how they can explore how conversations can help to better understand goals of care. And I'm just going to share a little bit about this. This is lifted from them with their permission. So he said things like goals of care priorities. This is from their research. The conversations occur within trusting relationships, including often with overlooked groups such as outreach staff. So that, again, hostel staff, outreach staff. And these conversations often happen in fragments over time and are not usually thought of as serious illness conversations. And the conversations are best phrased around how I want to live, how I want to receive care, rather than preferences for end of life. So very similar, really, to what we've found here as well. But really emphasising the richness of conversations, often with peers, outreach, social care workers, and often here hostel staff, which are often undervalued, but also the need for communication and sharing what those conversations, what people are saying, really. But obviously we need to ultimately really also work on how can we improve choice in place of care and care in a place that someone's choosing. Now, at the moment, there's very little choice often in a place of care. But where whatever the situation, we need to be bringing more support there. So we do need multidisciplinary support taken to where people are. With a shared understanding and training for everybody and collectively to advocate for alternative places of care is really essential as well. So I think we are, as professionals, a powerful lobby, and I think we have to continue lobbying for alternative places of care for the population. Care homes are not often an appropriate environment. Hospices obviously can only support people really in their last days or weeks of life. But there need to be other places where people, such as Nick, could be supported, where there is much more wraparound support. And there's only very few care homes for this population. So really briefly, we undertook a twinning project, which was linking hostels and palliative care teams. This was done, another piece I done a number of years ago, actually pre-pandemic now. And what we did, we trained palliative care nurses and social workers identified from a particular hospice to link with particular hostels, aiming to improve access to high quality care and support for people with advanced ill health and to reduce the burden on frontline staff, and trying to embed a training and support and an MDD approach. I'm not going to go into the project in a lot of detail because of obviously with the interest of time, but really to summarise what happened when we had this linkage. So the hostel staff went into the palliative care staff went into the hostel only once or twice a month. It was part of their sort of case, their job descriptions. It became, there was no additional funding, which was a bit of a problem because obviously they still had huge workloads. But despite that, with these meetings, there were regular case review meetings happening. They suggested, meetings to discuss anyone that the hostel staff were concerned about. They did informal training of hostel staff. The hostel staff felt much more empowered to refer to services and to challenge. They learned, for example, better person-centered support, and there was better communication and coordination with adult social care, and more discussion generally about death and dying and bereavement support also where needed. And it kind of resulted, there was better practical support, so hospital bed, for example, more packages of care. There was a planned death within the hospital during the time of the project, and that was helped by access to a helpline with the palliative care teams. And there were also some innovative solutions made to things like medicines management, which can be really complex in this situation, which we could talk about in more detail if we have time. And overall, the hostel staff were absolutely delighted with just this project really helped them. And these sort of quotes summarize that really. So initially, when we think that someone's going to die, we would have said, no, we need to move them off quickly. But then we started to change our way of thinking, saying, well, yes, this is his home. Previously, when we had a death, you do the instant report, the general paperwork. But for this person, we did something special. We did a vigil. We had cards made for him. Had it in the canteen, and his friends came, and there was a service. Because it was really clear also that from our research, some hostels just didn't acknowledge to the other residents in the hostel when someone had died. We had a horrible quote of somebody saying, well, the first we knew about his death was the week there was a body bag being removed. And if people's lives are sort of demeaned to that extent, if their deaths are demeaned to that extent, it makes everyone feel worthless, and its self-esteem is often incredibly low within this population. So actually being able to share and celebrate and share memories and celebrate someone's life is incredibly important. I've seen so many people die, so much over the last 19 years. So this project's invaluable, should have been done years ago. Now we're going to, after I'm going to hand over to Briony in a few minutes, and we are going to have a case, and it was a case that came from this project, and so there is more time to reflect about what happened within this project during that. But just to say, there are many examples around the UK. This is not a complete list. Actually, many projects all over the country now doing some fantastic work linking palliative care services and homelessness services. So there's homelessness-led, with Mungo's have a palliative care coordinator. There's sort of primary care-led, but a lot of them, the majority, I have to say, are palliative care-led, and all over the country. And it's often done with very little funding or by applying for funding on a case-by-case from charitable sector. And they've all relied on someone championing the need to support this excluded group. And a number of years ago, Hospice UK funded around 17 or 18 projects, which was fantastic, and many of which are still continuing. But I'm going to hand over to Briony now to conclude the talk and also share some of the other resources that we've developed.
Thank you, Caroline. So this really is just to sum up everything that we've spoken about in the last couple of slides. And the next part will be to give some resources that you might want to have a look at and some other things to consider. So to conclude, we have heard and we've seen that people experiencing homelessness are dying unsupported in unacceptable situations. The majority of people with multiple exclusion homelessness have experienced significant trauma, and that has a lasting effect, as you will well know, on access to services and approaches to healthcare. We've seen that hostel outreach staff are struggling to get support from health and social care providers, and this is impacting on the care that people receive and on the experiences of the people providing care as well. And that burden of support currently sits with frontline homelessness staff. There's much more that we can do about supporting people in the community, and we'll give some examples, as Caroline just has, of ways that we could do that. Identifying who'd benefit from palliative care support is complex and needs a shift in focus and parallel planning, as we've seen from work in Canada and work in the UK. And for high quality care, we need trauma-informed services with collaboration between health, including primary care and secondary care, palliative care and mental health services, social care, safeguarding teams, housing and addiction services. And crucially, all of the work that we do, we try and listen to and involve people with lived experience in lots of different ways and lots of different types of lived experience. And ultimately, we want to advocate for choice, a choice in place of care and care in place of choice. This might be an image that you're familiar with, but it's really powerful. And I think it sums up what we're trying to achieve really clearly and nicely. So we'll start on the left with reality. As it currently stands, we know that those with most needs receive the least. So you can see on the left, somebody's got loads and loads and loads of boxes and he's doing just fine. But people that are struggling have not as much, or nothing in this case. Equality is equal treatment for all. So everybody gets the same size box. On paper, that makes kind of sense. But when you look at what's actually happening, we all have different needs and we all need different things. And equity is when we are given what we need. So reasonable adjustments are provided for everybody. So just because some groups have more, it's leading to an equal experience or an equitable experience for everybody. And then ultimately what we really would love, which seems to be quite far away, is liberation, where all the barriers are removed and everybody has an equitable and the same what they need experience. So to conclude, really, we'll just share with some resources with you and different ways that you might like to get involved in stuff that we're doing and stuff that other people are doing as well. So we have a national palliative care and homelessness network, and these are monthly online meetings that anybody is very welcome to come along to. We tend to have 2 speakers at these, and it's a great opportunity to hear from others, to share what you're doing, to hear what others are doing, and to connect with others with similar interests. We've run 2 rounds of the network so far. We're currently having a little break, but we're planning to restart these sessions soon, February, March this year. If you'd like more information or you'd like to register, there's an email address there, and I'll put a link in the chat to join. It's a lovely community. We've got lots of different people from lots of different backgrounds, so there's space for everybody, and if you'd like to come along, please do. There's a paper here, I can also put a link to that, that's come from that network, and it's just different examples of projects across the UK that are aiming to support people experiencing homelessness with palliative care needs, and it summarises some of their aims and some of the common themes in terms of challenges and successes of those projects. So that could be an interesting read if you're considering doing something similar. Our next project, we've just had a grant from the NIHR to evaluate and continue to develop a community of practice intervention that we have created, and we're calling it Improve. And the aim of it is to create local, really place-based communities of practice for people from multi-professional groups to come together to work through a series of resources and videos, and to create a common understanding of what homelessness and palliative care means and looks like in your town or your place, and to think about collectively how you can work together and bring your different backgrounds, your different skills, your different resources to support people in your location. So we offer, it's all free, there's free training for people that might like to be a facilitator of this community of practice. And what a facilitator involves is identifying those in your local area that you think should be involved. And we would suggest the more the merrier, and the wider the group of people that you can muster, the better. So we have examples of communities of practice that have primary care, palliative care, social care, secondary care, somewhere the police came along, which is really good. And everyone is encouraged to come. And basically, facilitators are given the resources and the materials to deliver 8 sessions for their community of practice. They tend to be online, but you might do a hybrid version to get everybody together, first of all, with the hope or the expectation that communities will continue to meet after the conclusion of those 8 sessions. And what you get is a series of video presentations that you'll watch together and discuss, and it creates opportunity for people to bring cases and discuss problems and challenges and what they might actually do about them, and how to work together to explore possible solutions to current challenges. And you get access to resources and videos and all sorts of things. And if you're interested in finding out more or becoming a facilitator and starting your own community of practice in your local area, the next round of the free facilitator training will be on the 26th of Feb from 9:30 till 12, with the second part being on the 26th of March. And you would need to be able to come to both, because we're going to kind of talk you through all the different bits and bobs and what to do with it, and how to get your community up and running. And we, as I mentioned, we have a project to evaluate this. So we're running the training, and then we'll be looking for test sites to take part in our kind of more in-depth evaluation of that intervention to see if and how it works and what other things that makes it work. Other things that might be helpful is the Homeless Palliative Care Toolkit. That's homelesspalliativecare.com, I believe, Caroline, is it? I'll check. Yeah, it's com. I'll check. And we designed this. It is .com.
It's just fallen off. Yeah,
that's all right. We designed this initially for hostel staff, and you can see on the left the different kind of chapters to the toolkit. But we found that it's been really helpful for different professional groups as well. So it's got some really nice tools in it. There's tools for kind of having conversations about wishes and preferences. There's some of the stuff that we've talked about today, and here's a nice example. So this is a person-centered care tool for having conversations, and it helps people to map out what's important to them. So it puts the person in the center and it locates important issues to consider. And these are some of the kind of prompts that you might like to consider for each of those stars. So questions about physical well-being, treatment and care, hopes for the future, for example. So it gives hostel staff in particular some tools that they might need to start to explore conversations in a way that might be less threatening. Another resource to point you to is the film Less, which is a really wonderful film about personal experiences of homelessness. So it's a film of personal stories and journeys to health from people who have experienced and overcome homelessness. Again, I'll pop that in the chat in a minute, but would really encourage you to take a look at that. And it's been so helpful for lots of different things. If you're kind of doing a training, or if you want to just really show people what it means to be homeless and what access to health can look like. Well, not access to health, but just what it's like to be homeless can be like. It's a really lovely way of doing that. So I encourage you to take a look at that as well.
And just say it's only 12.5 minutes long. So it's a nice short, can be an introduction to training in quite a nice way.
Finally, some other useful resources. So we developed the tip-in recommendations for involving people with lived experience of homelessness in palliative care research. So if you're doing any research on this topic, you might want to have a look at those. If you're planning out some involvement activities, that's a nice place to start. Pathway and the Faculty for Homeless and Inclusion Health are an excellent group, and they provide standards for providers and commissioners. They have publications, a network, local meetings, training, and an annual conference. So check that out at pathway.org.uk. Fair Health also have some excellent training around palliative care and homelessness, and also around adverse childhood experiences, and trauma and training. So take a look at that too. And Anemo is another excellent provider of training if you're looking for more information. And the Queen's Nursing Institute is another good place to have a look at. And there's 2 other homelessness and palliative care films, one from St Anne's and the one called Tina that was commissioned by King's College Hospital very recently. So lots of good things to check out. And I won't go through this, but we'll send a list of publications that you might like to read. And just a big thank you, really, finally, thank you to everybody that's contributed to the work, particularly people with lived experience, the amazing hostel staff and palliative care teams that we've worked with. So with our funders, the Oak Foundation, NHSC, NAHR and Marie Curie, people from Pathway, so Dr. Nigel Hewitt, Julian Daly, Rafi Rogans-Watsons and Natasha Palapane, St Mungo's and Marie Curie department at UCL, as well as people from Marie Curie, the charity too.
Great. So I'm just going to introduce a case now, actually. I think we've run 5 minutes over, so we should be all right. So I just want us to think about, before we break into breakout rooms, around this case of Abby. So I mentioned the twinning project. So Abby was somebody who the palliative care team, when they first started the project, were called to see Abby. And this is the information they had. Abby was 42. She was living in a hostel. She was very unwell, been in and out of hospital with decompensated liver disease, untreated hepatitis. She had chest infections. She was had episodes of unresponsiveness when she ended up going to hospital. She always refused to go to hospital. She didn't want to go to hospital ever. So hospital staff would call the ambulance when she was collapsed, and then she'd go into hospital, and then she'd often self-discharge as soon as she got there. She was alcohol and drug dependent. She had absolutely no relationship with anyone in the hostel or with any other services. The hostel staff didn't really know very much about her. And they were so scared that Abby was going to die that they put her in a room in the reception area with glass windows so they could keep an eye on her. And they phoned, it was actually just at the start of the project, we hadn't actually officially even started, they phoned in complete panic, they needed help. So our amazing palliative care nurse and social worker went in to see her. Now, what we're going to do is, oh my goodness, what's happened? Sorry, just at the critical moment, there we are. So this is what, in your breakout rooms, we would like you to think about. Could you consider what you would do if you were asked for advice. Obviously, you all got different roles, people in this group, but think about as a collective within your groups, and how would you approach the situation, and think about what might help Abby, what might help the hostel staff. And really, in considering this question, think how you would use a trauma-informed lens to help you work with, support and build a relationship with Abby. Now, I'm just going to put it back to the previous slide. What we suggest is that you actually, if you could do a screenshot potentially of this slide. We're also going to, I think we're going to put that in the chat as well. That's been done. And this slide with the question. And then I believe you're going to go into breakout rooms, and then we will reconvene and discuss your reflections and your thoughts. And if there's time, I will also share what actually happened in Abby's case as well. Does that all make sense? I'm going to stop sharing now, if that's okay. Is everyone ready?